I guess we should start, Shiza. It's our 9 here, so we can start if ma'am is all
Yes,
ready.
we can start.
Okay. Can you hear me, Dr. Zheala?
Yeah, I can.
Okay, so that's good. Shiza, can you give a little bit of introduction of what we are doing and what we are planning to Dr. Zheala so that she knows what we have been through?
Yes, sure. Dr. Zheala Qayyum and all the members who have joined us this evening, Assalamu alaikum. I'm Zheala Qayyum, finally an MBBS student from King Edward Medical University. And on behalf of ChemPsych, I welcome you all to the talk on the series Choose Psychiatry. Before I tell you what exactly ChemPsych is, I'd like to take you back to the point where this idea came from. It was back then in September 2020 when I, along with some of my student fellows from King Edward Medical University, got the opportunity of attending a psychiatry internship program held by the Department of Psychiatry, Mayo Hospital, Lahore. It was a 15-day internship program where we saw patients, discussed research articles, their methodologies, had presentations, table discussions, and whatnot. Previously, having very little knowledge of this field of medical sciences and realizing how we are lagging behind the world here, we felt the need of having such initiatives more often. So basically, this aim of creating a co-curricular platform for the students of King Edward Medical University laid the foundation of ChemPsych. ChemPsych aims at creating a learning as well as research community for medical students all across Pakistan, exploring the areas yet unknown to us and encouraging and inspiring our students to join and contribute to the field of psychiatry. ChemPsych hopes that this initiative will help us bridge the gap that lies in psychiatry between Pakistan and the rest of the world, will facilitate our students as well as the future of psychiatry in Pakistan. Thank you.
Thank you so much, Shiza. Before beginning, I would like to welcome Dr. Nazish Imran as well, who has just joined us. Thank you, ma'am, for joining us. So let me introduce Dr. Zheala a little bit. Dr. Zheala is in charge of psychiatric emergency in Boston Children's Hospital.
Hi, Zheala, how are you?
So lovely to see you. Thank you for being here. Thanks.
And secondly, she is the training director of Child and Adolescent Fellowship in Children's Hospital as well. Meanwhile, she is also having some faculty positions in Yale Medical School and Harvard Medical School. So Dr. Zheala, thank you so much for finding out time for us. And before we begin, tell us a little bit about yourself and how did you become a doctor in the first place? Like, how did you end up in a medical school? Then we will follow you up for a journey to psychiatry.
It's really a pleasure to be here, and thank you for having me. I can tell you about my story, but first of all, I would like to say a big thank you for pronouncing my name correctly. My most, I think, sort of poignant memories from being in King Edward were that I had to stand in the start of every class. And when they would sort of speak out names or they would be going down the roll numbers, would 110 pe aake phas jate the, and you could see this sense of bewilderment on everybody's face. Or phir mujhe khade hoke kehna padta tha ki bhai, this is my name, it's Zheala, and I had to spell it for everyone. And I did this for the entirety of my 5 years. So that's probably one of the most outstanding memories of King Edward. The truth is that my father was a professor of anesthesiology. And when I was in FSC, he started saying, you're going to go to medical school. And I had no desire to go to medical school. I wanted to be an artist. Plain and simple, I wanted to go to NCA. I grew up writing and drawing and playing music. And I thought that this is what my life was going to be. And my father was like, you know, aap doctor ban ke artist ban sakte ho. That thing is not going to go away, but aap artist ban ke doctor nahi ban sakte. And so he and I had an agreement that if I score high enough to get into King Edward, I'll do it. But if I don't, then I'll be free to do whatever I choose. And unfortunately, I lost my wager. I made it by this much. and I kept my word. So that's how I ended up in KE, and I was completely lost. If my voice is breaking, just let me know.
No, your voice is completely fine. Dr. Fozia, I think your internet has some issue on your end. Please look into it. Yes, ma'am, continue, please.
So I guess my saving grace was that in every anatomy substage, I'd have to sit and draw 5 diagrams and submit them. And that was the entirety of joy in my first 2 years. I was happy because I was drawing. And I didn't realize that 2 years had passed, although they were difficult years. But I think anatomy kept me going. And then I was kind of lost after that. I had nothing more to draw. And so around that time, I joined the literary club and Chemco and KDS. So I guess I did medicine, but I needed all these other things to keep me motivated to pay attention to studying. And I don't think I would have gotten through without them. So yes, that is the sad story of how I ended up in KE. But when I was here, end of my second year, start of my third year, my father got transferred as a full professor of anesthesiology in Mayo and King Edward. And then he became the chief warden of the hostel. So I don't know, aapko yaad hai ki new hostel ke baad jate hain, to there's the chief warden's residence. So in my third year, I moved there. And I became the Rosen of all my classmates who used to live in the hostels. And so that sort of brought me closer to KE in a lot of ways, not just proximity geographically.
Matlab ke you are one of the few students who has actually lived in boys' hostel.
Exactly. Yes.
So that's interesting.
I think with the Mayo Hospital ka back gate, there was one day where there was an emergency and I had to go home. Or normally I used to go the back way, like in that day I went from the front gate. Or mujhe kitne logon ne roka, agle aap kahan ja rahi hai? And I had to tell them like ghar ja rahi hu. And it was like fine, they realized who I was and they let me pass through. But yes, I caused a lot of chaos that day when I went through the front gates.
Yeah, that would have been a sight. Actually, so ma'am, like you have said that you are not very interested in medicine and you are more interested in arts. And well, most of the students who come through first year, they have literally no idea why they are coming into the medical school. Most of the time, it's just the flow because they had good marks in metric, then good marks in FSC, and fortunately or unfortunately, they end up to K. So what was the time when you were comfortable with being a doctor? Or you are still struggling?
No, there was a time, I think afterwards, it was like, okay, med school, khatam ho gaya, what do I do with myself now? I remember telling my father and my mother, you wanted this degree, here it is. But then it was just like, what do I do now? And what I did was, I started studying for my USMLEs. I think one of the plus side of things was that my father was working with a lot of house officers and medical officers, and he had a good idea of what people's sense of direction was. So he sort of pushed me that way and said, just take your steps and go, and then you can do whatever you feel sort of, aligns with your interests. So I took a job outside of medicine. I actually worked with Invisalign, which are the invisible aligners. They started off in Pakistan. And so for that first year, I was working with them and I was studying on the side. So I know house officer salaries have increased a lot since then, but at the time when I was coming out of graduation, I was like, I'll make more money, I'll have fun, it'll be something different. And so I studied for my USMLEs because I really couldn't see what else could I do. But then I thought about psychiatry, and I loved surgery, by the way. That was one thing I was considering. I've been in the OR with my father since I was 13 years old. And the day I entered med school, I was fortunate that my father's close friends were the professor of surgery in North Surgical and West Surgical, and I knew them since I was very young. So the day I entered med school, my father would take me on with him to the private practice, and मुझे वहाँ पे scrub करा के retractor पकड़ने के लिए खड़ा कर देते थे, and I would, you know, I had a lot of exposure to surgery, and I really liked it. But I don't think I wanted the lifestyle. I just can't wake up early in the morning and start a list. So when I had to think about what I was going to apply in, I thought psychiatry. I really appreciated my rotation in psychiatry. The first day I was late to wards, and I think Professor Aftab was an assistant professor, or unki class thi, and I was really late and I was sweating it. So bilkul Mayo Hospital ka jo psychiatry ka jo board ka entrance tha, wahan pe there was this gentleman. I thought he was a PN. उन्होंने कहा कि डॉक्टर साहब मैं आपको क्लास में लेके जाता हूँ, and he took me all the way. I was late, but he got me to the right place, and the next day too he like escorted me to exactly where I was supposed to be. And then I heard he was a patient there who thought he was the gatekeeper and he was escorting everybody around. So I had a pleasant experience. But when I thought about psychiatry, I thought it was probably the closest I'd get to art. That art was all about the human condition. It was all about expressing people's view of life, how they felt about things, how they made sense of things. And I thought that was really the one place where I could see the two coming together for me. So whether it is true or not, I think it is, that it gives you the most intimate reflection into the human condition, stuff poets and writers and artists write and draw about. I encounter it every day with every patient. And you get that closeness that you almost do in surgery. It's a very different approach, but it is very much a privilege to be so close to someone. So that's, I think, how I decided on psychiatry. I had a couple of other programs I applied to, told my father, yes, I am. I didn't tell him I was going to do psychiatry. And then when I told him I matched into psychiatry, he was like, jo marzi karna hai karo. And I was like, okay, fine, that's good. And so, yes, that's how I ended up here in the US.
Well, that's great. So finally, आपके father ने कहा कि अब आप जो करना चाहती हैं वो करें.
Good.
So wasn't he like, why psychiatry में ना जाओ? Because we see this kind of, I wouldn't say negative emotions with respect to psychiatry, but I would definitely say that the doctors, and specifically the doctors who have been professors in some other specialties, they are not very supportive of their children, or someone going into psychiatry. So what was your father's response, or maybe the people around you at that time?
I think my father was very supportive. I think he thought as long as I am in the US and I'm doing a residency, I'll be fine. And when I think as an adult, look back towards his decision-making process, I can appreciate where he was coming from a bit more, because he was an anesthesiologist. He worked with a lot of women physicians. And I think in his mind, if he thought about his daughter being financially independent and being her own person, being a physician was what he saw, autonomous, independent women doing. So I could see that was where his perspective came in. But definitely, I think even in my like relatives or friends or classmates, it was just like, "Bichari ke number nahi aaye steps mein, isliye psychiatry mein ja rahi hai," or "That's going to be tough," or "Are you sure it's even medicine?" And I remember someone close to me once saying, like, "You're a psychiatrist. It's not like you're an ER physician or you're a cardiothoracic surgeon that you're saving lives. But I think in my career in psychiatry, when I lost patients, was when I realized just how many lives we're saving. And so I may not be the surgeon who goes in and just fixes something, but by God, we are trying so hard to keep people alive. And so I have learned to discount what people say about psychiatry, because it just feels right to be in this profession and doing what I'm doing. And I've had enough people support me and mentor me throughout the process that I think that crystallized really well.
Yeah. So you told about the mentors you had
Mm-hmm.
that who helped you actually becoming who you are today. So would you tell us a little bit about your journey in residency, or the people from whom you have learned a lot, or someone who might have inspired you more to become a better psychiatrist?
Absolutely. It was something I actually saw my father do. I don't know, and I'm hopeful that the culture has changed, but there was a significant hierarchy with professors, and आपका दिल कांपता था उनके पास जाके बात करने से. But I think one thing my father modeled for me was to be approachable. And I remember one day, my father's office was, I think, जब आप North Surgical enter करते हैं, तो right side पे, it used to be the head of North Surgical's office, or left side the anesthesiology office. I don't know if it's the same right now. But I was waiting to go and see my father, and I think it was a medical officer who came out of his office, and he was very tearful. And so knowing my father, he's just like this fun-loving, laid-back person. I was like, Baba ne kisko rula diya? And so I asked him, and he was like, nahi, kuch nahi. And then when I was like, aapne kya kaha? And he's like, I didn't say anything. He just had a bad breakup. And so I thought, okay, I think, and I don't think I made much of it at that moment, but I thought, when I look at mentors and supervisors, I think he sort of modeled what I wanted to be, or who I wanted to be, or what kind of person in that regard, was that people, when they're suffering and struggling, can actually come to me, particularly my trainees. And so I think that's the image that I took with me when I went into residency. And I kept looking for those people. Sometimes they're assigned to you, sometimes they're not, but I was lucky that I had a mentor from my very first year of residency who I met during my interview trail. And he sort of was, so let me backtrack. I think one of the things that is most important as a learner is for someone to reflect back at you, what are you good at? I think being super achievers or very conscientious people, we don't pay attention to what our strengths are. We're always focused on what am I not doing really well in. And so one of the most, I think, helpful things supervisors, our attendings can do for us is reflect our strengths and our weaknesses, or the areas we need to develop more. And so the thing that my mentors and supervisors, I think, did really well for me was I didn't know what I was good at, and I didn't even know what to do. And I went into psychiatry saying, okay, I chose this. I don't know if it's the right fit for me. But as I was getting more and more feedback and positive reinforcement, both from the patients I was seeing and then the attending saying, that was well done, or the way you can actually connect with people is something that comes naturally to you. And I didn't know what comes naturally to me. I just go do things. And it's simply the same sort of, and I think as a child psychiatrist, we appreciate the developmental model of what is that teachers and parents do for their children. It is exactly that in training, if you're a medical student or you're a resident, your supervisors and your professors are playing the same role of modeling for you and then reflecting back what are you doing well and what needs to change. And so that's how child psychiatry came up as well. Was in my second year, I was doing my child psychiatry rotation, and the unit chief was watching me, and he and I had a few cases together. And so at the end of the day, he said, you know, I talk to kids, they really like talking to you. And so then I was like, yeah, well, now that I think about it, it comes really easily to me. I don't feel like I'm making a lot of effort to connect with kids. And so had I not heard that, I probably wouldn't have thought about it so seriously. And then when I was in the consultation service, I loved the teachers there. It was just wonderful learning, but they were also really pushing me that you need to know this, and really not just looking at what I was doing, but much more my career and personal development as a physician. And so that, I think, and one of them was the same mentor I had from my very first year of psychiatry. And he was my mentor and my peer and my sort of professional father throughout my residency and my fellowship, that I went back and did a consultation fellowship with them afterwards, because it was probably the best teaching I got in the entirety of my training. And I think we all need some Yodas in our life who can teach us wisdom, but also it is that dyadic relationship of the master and the apprentice, or the Jedi and the Padawan. So because medicine is is still following that model of apprenticeship, you need those people who will bring you along. And then I remember the day I graduated from my consult fellowship, the same mentor pulled me aside and said, you know, I've done what I needed to do for you. Now it's your turn to find someone better than yourself, and you have to bring them along. And I think that is something I've tried to do, or hope that I'm doing for all of my trainees, is that you just pay it forward, and that's how it continues.
Well, that's wonderful. So now that you are a mentor to many mentees, so how would you see, like if you had to point out like 3 qualities of a good mentor, what would be those 3 qualities?
I think one of them definitely has to be that you are approachable, and you care. I would put them together, because the greatest thing that we do is that we invest in our trainees, and their success is ours, and we want them to be better than us, just like parents want their children to surpass them. The other thing I think is, so this is where supervision and mentorship comes in, is that there are 3 categories. One is supervision, which is very specific to a task. There is coaching, which can be peer coaching, or it could be someone who knows a little more than you or does it well, and you say, I need help to get better at this. And then there is mentorship, which is really much more holistic in terms of development. The difficulty lies when supervisors and mentors forget where the learner is, because we've already gotten our pattern recognition, we get the bigger picture, but we forget that the learner is still learning those very basic steps. So I think the other quality of a mentor would be to be able to meet the learner where they're at. Not where you're at and how you're seeing things, but more so to have that perspective and be able to break down things for them. And I guess the third thing would be not to have your agenda of how you want your trainee or your mentee to be, but your job is to help your mentee or your supervisee be the best that they can be based on their strengths. And you're going to have to develop those rather than, I think, you should be doing this. No, this is your strength. This is what you do well. These are the things that will get you into trouble if you don't pay attention to them, and you sort of help them be the best that they can be.
Thank you. Well, that's a very important thing, that if a good mentor is being able to actually walk alongside his or her mentee. So just flipping the coin, what would be the 3 qualities that you would like to have in your mentees or in your students?
I get asked this question a lot when people are interviewing for a fellowship. Or like, what kind of candidate are you looking for? Or what kind of applicant are you looking for? And I think I probably won't say there are three. There's just really one for me, is that I really want my trainees and my mentees to want to learn and be curious about learning. Other things will come along. There's certain things that cannot be taught, but people, I think, if they appear disengaged or they're sort of trying to take the shortcut rather than, learning about something. But I think as long as people are curious and they keep that fire burning, you can be very successful. So I don't think I'm very picky when it comes to mentees. It's like, if you want to learn something and you have that passion and desire to better yourself, I'm here to help the best I can.
Thank you, ma'am. This was a good answer, actually. So just wanted to see, let's take things a little bit backward. Like, you've told me that your journey till now in psychiatry has been a very smooth one. I really doubt that it has been really this smooth. So I would like to know what problems did you face in your early career in US, or maybe when you started working as a consultant psychiatrist, as an attending. How were the situation, and if given the opportunity, what would you change retrospectively?
So I agree, it has not been smooth. It's taken a lot of work, but I also think that thankfully I've been very blessed. Alhamdulillah, it's gone as smoothly as it could have. The transitions were hard. And I think one of the biggest things was, I know the guys in my class, they came to the US for electives. I remember none of the girls did that I knew. I had no one telling me much about what my career path should be. So I think that was definitely a difficulty and a disadvantage. That I was very glad that my classmates who were here were very supportive and helpful, and people, I had a couple of really good friends from my class who were applying, and they sort of brought me along. But sitting in Pakistan and thinking about, I'm going to apply here and this is what it's going to be like, I had no idea. I didn't know what the good programs were. There was no one telling me anything. And so I had to navigate that all by myself. And during that time, I also got married, but then I came here by myself because my husband was going to come later. And so that transition by myself was, okay, no one told me I have to get a social security number. Nobody told me how I get a driver's license. Nobody told me how I'm going to get a car. How do I get an apartment? And I was lucky that I had two classmates who were close by, and boy, they helped me out a lot. And so I'm very glad to, and grateful to them. But it's all these little things nobody prepares you for. And if you've had a very comfortable and sheltered life, this is your first step into autonomy in a new place. And so that part was difficult to navigate. And you're doing all of that stuff while you're starting residency. So there's a lot of like moving pieces. And I think that was hard because it's a new system. I didn't come here for electives. I didn't know anything about writing notes. Nobody made me really paid attention to my med student notes at Mayo Hospital at that time. And so the first time I wrote an order, I wrote it wrong. So all those things, because I didn't do a house job, I didn't have that internship experience, I really didn't know a lot coming in. So definitely I would change that part of things. Other things that were difficult or challenging, I mean, I came here right after 9/11. So I applied in 2002, And then I started my residency in 2003. So there was a lot of visa issues at that time. People get worried about Islamophobia. Yes, there was a lot of difficulty at that time, but I can say that it was around, but really it wasn't as bad as I thought it was going to be. Patients were, I loved working with patients. I had wonderful people that supported me throughout. The other transition into real life and after like training was, I realized I love learning and training. So letting go of that and becoming a grown-up and starting to work was another challenge. And partly, I think because of my visa status, not having a lot of guidance, I feel like I could have applied to more programs or looked at other options in terms of jobs, but I was really glad where I trained because I think they really trained me well. And the reason I say that is after 2 years in a community hospital, I got recruited to Yale and I didn't approach them. They came to me. And so I was really grateful to the program that it trained me well. So the other difficulty that I faced in my life was being at Yale, where I was sitting with people who had done undergrad at Yale and med school at Yale, and they had done their residency and their fellowship, and they'd been attendings there for years. And here I was, Neela Gumbat se leke Yale tak. And I had a very difficult time finding my confidence and not feeling really let down with that imposter syndrome of questioning myself, not having difficulty like speaking up at times, or just, you know, just being and accepting and being grateful. But eventually I grew into it. And most of that reinforcement came to me from my trainees. And so, you know, I think one of the things I learned is that as a leader, you may not have a lot of influence depending on what level of leadership you're at, but you can definitely influence your bubble of people you're around. And so I ran an adolescent young adult unit. I was responsible for my staff, but I was also blessed that every single first year intern, every PGY1 rotated through my unit. And I had the privilege of teaching each and every one of them. And so I got to know each one of them. And even now, once they've graduated and they're, you know, in their own respective careers and very successful and leaders in the field, I'll still get a call. I'm stuck. What would you do? And I am so blessed to have built those relationships. So I think I didn't know how good I was, but they felt I was, and that sort of reinforced my place while I was working there. And that sort of propelled me forward.
That's something to look forward to. So actually, I was thinking about when you were talking about how your initial days at Yale were, you were struggling with the imposter syndrome, and there were people who had done their undergrad, then medical school and training from Yale. So what difference did you see from someone who has come from Pakistan and who is a psychiatrist, and someone who has been there and is also a psychiatrist? Definitely the residency structure and a lot of things are similar across America, but what differences did you see between yourself and the people there that you have now filled the gap with?
I think, well, I think the first thing is I think I have greater appreciation of poverty. And I have not forgotten walking into Mayo Hospital outdoor and seeing God knows where people are carrying their loved ones from. So when I was seeing patients, I could tell the difference, but I also thought you bring another level of awareness, of empathy for people who feel different and who, for whatever reason, feel different. And I think that is one of the reasons I love child psychiatry, is because kids grow up feeling different in adolescence, and you're trying to figure out, where do I fit? And I just could always draw that parallel, because I was always trying to figure out where I fit. I was trying to do that while I was in KE, because here are people who really want to be doctors, and here I am trying to fight it every day and say, I will go home and draw my Grey's Anatomy drawings. So I can definitely see that. I also think that we are trained to work hard. And we're also more, I think, fundamentally respectful of hierarchy. And when you actually come here, that's a big change. That everyone is, call me by my first name. And I remember my mentor said, why, now that you've graduated, why can't you call me by my first name? And I said, well, it just feels so disrespectful to me, and I just can't do that. And I think my fellows and my residents see that too, because I got abbreviated to Dr. Q. And so nobody knows who Dr. Qayyum is. Everybody knows who Dr. Q is. And I was like, fine with that. But I noticed that none of my residents were calling me Zheala either. Even I would encourage that, but that wouldn't happen. And so I think those are two differences that I see, but I also feel, so here's something to think about in psychiatry is, I would get Pakistani patients, I would get Indian patients, I would get Bangladeshi patients. They would look at me and they would just like, oh my gosh, you get where we're coming from. And so there is this element of familiarity. And yet you have to be very careful, because yes, because I can understand where you're coming from may not change my recommendations. And so if I have a young 19-year-old with their first episode of psychosis, and the mom and the dad are like, kuch nahi, we love this kid and our love should be enough to make him better, I can say, yes, you have done whatever you can as a parent, but this treating your having the right treatment for your child is also your obligation as a parent. Or I would come in and they would say, humne ye wali surate padhi hain, surah nas bhi padhi hai, and I was like, dua ke sath dawa bhi bahut zaruri hai, and how do I bridge that gap? And so it is important, because these are our blind spots, and these are the expectations patients who identify with you will put on you. And knowing that you need to be sensitive to where they're coming from, but also do your due diligence in figuring out what is the best treatment for your patient. So those were some usual dilemmas that I thought was interesting.
Yeah, thank you, ma'am. So a few days back, we've been talking with Dr. Nazish about the gender bias within psychiatry. Have you felt that gender bias within psychiatry, or do you think that it is more in other fields of medicine, or it is less in psychiatry, or maybe it is more in psychiatry as compared to other fields? What are your views on this?
I think so this is how I would see it. And I can only speak to sort of the American perspective, which is where I am right now. There's almost like an equal number of women and men coming into psychiatry most of the time. However, when you look at how many women are in positions of leadership, how many women are full professors, they're not half. There are far less women in leadership positions than there are men. And I think that is fair across the board in psychiatry. And that is, I think, parallel to what it is like in other specialties too. So when you look at a med school class, half to more than half will be women, but their representation in leadership positions is less. So I think that's where you see the bias. So yes, there is, I would say.
Definitely, that's something we can actually see everywhere around in Pakistan, in US as well. So before we go to the chat box, please tell us like why someone like maybe there's a third year medical student and he thinks that he might be interested in psychiatry. He is not sure yet what he or she should do to come to a decision that finally, yes, I am the person who should now pursue psychiatry, or maybe this isn't something for me. What would you suggest to that third year medical student?
So one of the things that medical students, I think, have a great learning curve for is uncertainty in medicine, where we don't have clear-cut answers, where you have to sit with that uncertainty and how do you communicate that to your patient. And I think that is even more prevalent in child psychiatry, where kids are in different stages of development. We don't know who they're going to become or how things are going to evolve in the long run. We can have an idea about it, but we don't always know for sure because they're still growing and they're developing. So I think one of the things for a med student to ask is how well do they sit with uncertainty? And there are things that are built into psychiatry, because I know some of the concerns I remember hearing from medical students always is this going to take a toll on me? Is this going to be emotionally laborious? And I remember asking Dr. Aftab the same question. When I was a medical student, I'm going home.
Sorry to cut you, ma'am. I would like to ask the same question to you right now. Does this, does the working as a psychiatrist makes you more vulnerable to psychiatric illnesses? That's a very common myth, as well as perception, as well as a question that we have been receiving for a very long time now.
So yes, I went to Dr. Aftab and said, I go home and I'm feeling heavy. Is this supposed to be normal? And I remember him saying, no, that's not how it's supposed to be. And that's not how it is. And the more you do this, the easier it becomes. So that's what he told me way back then when I was, what was it, third year, fourth year maybe? And I think that still holds true. So psychiatry, and particularly, I can only speak of my own training experience, is one of the very few specialties that actually has supervision built into it for exactly this reason. Because unlike other instruments where you've got your scalpel and you've got your tractors and those are the instruments you're using, or you've got an MRI, you've got a blood level that tells you the answer, the biggest instrument in psychiatry is going to be you. It is probably the ultimate use of the self. And yes, you will get better at using it and using it appropriately and being able to say, the stuff that's coming up right now, that's my stuff from my own experience, versus this is what this interaction with this patient is creating in me, and this belongs to the patient, not me. And which is why psychiatry has a residency, and it's 4 years if you're doing adult psychiatry. It's 3 to 4 years for general, and then 2 years of child psychiatry if that's what you're going to do. I have 6 years of training, and it took me 6 years of training to be able to come to a point where I have a better understanding of myself, and I can use that to understand my patients and what's happening in that interaction better. So does it make you more vulnerable? No, I don't think so. I think it gives you enough tools and enough strength to be able to take care of yourself. The question, however, is a different one, which is, are people who are going into psychiatry self-selecting? Which may be a very different thing, that people who may have had experiences with mental illness or depression or anxiety that they have struggled with, they find that because of my own struggle, I may have more compassion and empathy and a better understanding for my patients. So that is a very different thing. That is your thing that you have to deal with and take care of for yourself. And then you will also continue to learn how to take care of your patients independent of that. There is something in psychiatry that is highly encouraged, is go to your own therapy. We always tell our trainees that you should have your own therapy. It's not mandatory, but it will help you be a better therapist if you're on the other side of it and you know what it's like. And then it also creates that space where you can, in addition to supervision, be able to process difficult experiences, because no one comes to us when they're happy and, you know, gleeful, unless they're totally manic. People come to us because they're in pain and they're suffering. And so I don't think carrying that pain and suffering is something unique to psychiatry. We do that in every specialty. However, in psychiatry, we pay attention to it, and we are trained to pay attention to it. Whereas I work in pediatric hematology, oncology, and palliative care. And I remember I had a patient who died, who I had taken care of for 3 years. And there was a medical student. So here they have a buddy, like a first-year medical student follows a cancer patient through all of their treatment, all of their appointments. And since this was a 12-year-old at the time that we saw this patient, followed him to school, home, everywhere. And when this patient died, I asked the PD Hemonc department, has anyone checked in with that medical student? And they were like, well, you know, if they need us, they'll come to us, and then we'll address it. And so, and I was like, well, do you have a protocol or something for how do you deal with patient death? And then how do you support your trainees when your patients die? Because I mean, I remember my PD Hemonc list. I work as a psychiatrist. I used to work as a psychiatrist in that clinic. When I look at the number of patients I had, 2/3 of them had passed away. And so it is a norm. So you would think that, you know, people pay particular attention to it. And I was surprised that there isn't. However, my area of research is really how do we support our trainees when their patient dies by suicide? And so we make an active effort to check in. So I think there's more awareness and a more deliberate effort in psychiatry to be more attuned to the emotional and psychological experiences of our trainees when they're taking care of difficult patients.
Thank you so much, ma'am. One last question before we go to the chat box. I just got remembered that you have served in the US Army and you have been deployed to Afghanistan, if I'm not wrong. Mm-hmm. So can you share that experience with us? What were you doing in Afghanistan and what were the things there and how was your experience?
So my husband was planning to join and I was like, you go, I go. And so I remember after I finished my officer basic, so this is the reserves, it's not active duty. This is something you do on the side. And because there's a great need for physician and healthcare providers, a lot of the civilian physicians, nurses will partake in the reserves or participate in the reserves. So that's what I did. And then after I finished officer basic, very shortly after, I was sitting at work and they said, you're getting deployed to Afghanistan. You have 4.5 weeks to get ready. And so I got shipped off, and this was 2012. So things were pretty rough back then. I was on base and I was attached to the NATO hospital, which was great. It was actually, I mean, it's not an experience I would have had otherwise, right? I mean, before that, before I got deployed, I mean, the only things I had to do was I show up in my uniform once a month and just good twice a year, and that my range. Can you hear me?
Hello. Yeah, now I can hear you.
Okay. It broke,
so,
yes.
Yeah.
So you have to keep up with your PT test twice a year, and then you go to the range once a year. And so that was all I was doing before then. But then you go to a real combat zone, and it is different. It was I think probably one of the greatest learning experiences was that it's something very different I've ever been exposed to in my life. Of people in that moment when terrible things are happening, and even we got civilians in our hospital as well. So that part was, I mean, something unforgettable. It was definitely difficult because we were constantly under fire, and we were seeing some very difficult things in the hospital. But the NATO part was cool because, you know, the OR people were from Belgium. And then, you know, we had the Romanian psychiatrist and the psychologist who would join us. And there were the Germans and the Australians. And then you had the, you know, the Afghan National Forces. So it was wonderful to have such a international collaborative effort. But yes, it was constant fire, but and then a very stressful thing. So I remember my very first clinic day after I had two different clinics, and this was in the hospital, and I didn't have my hospital ID at the time. And so one of the Navy people yelled at me and said, "Where are you going?" And I was like, "Zheala, you know, this is your first week in Afghanistan and you're already messing up. How are you going to get through your whole deployment?" And then, you know, the 2 days later, the psychologist on my team came to me and said, you know, it was like 6:30 p.m. and I was wrapping up, and he said, "I just have this one person from the trauma bay. Can you just quickly check in with them? I think they might need some medications to help them sleep." And so I said, "Bring him in." And the same guy walks in. And he sees me and he just does a double take and he tries to get out of the room. So the psychologist has to grab him and bring him back. And he was like very apologetic, but not really. He was more ashamed and embarrassed. So anyway, I didn't bring up what had happened and just, you know, tried to treat him, and found out he was having a lot of panic attacks and flashbacks. And so anyway, I took care of him for about a month and a half before he was going back home. And so right at the end, I asked him, "Do you remember our first meeting or our first unscheduled appointment?" And he started laughing and says, "Yeah, that was the day when I was supposed to go back and I was told that I have to wait another month and I will not be able to go home. And so you were passing and I just took it out on you." But I also remember thinking that I'm a psychiatrist, and how people feel and what's going on with them is something I take care of every day. But when I was stressed out and when I was anxious and I was in a totally different environment, that was the first thing that went out of the window for me. And it was just brought me back to just, even if I think I naturally do this, I have to be much more cognizant and attuned with my own stress level. That I failed to appreciate that in someone else at that moment when I lost sight of that. But yes, I came home, thankfully, safe and sound.
Well, that sounds like an experience. So yeah, just picking on your last statement that psychiatrists do get overwhelmed. They do feel like talking out. Are there any opportunities for you in America or maybe in your community for having a little bit of safe space where you can vent, where you can feel better?
I think you develop those professional networks and your peer relationships. I mean, I'm very grateful that, you know, Dr. Nazish is a wonderful colleague, support, and hopefully dear friend. You build these connections. And so when things are stressful, when you're sort of lost, when you just need another person to bounce something off of and say, "Do you think I'm doing the right thing?" You build those peer supports and peer relationships as part of moving forward at every stage. So when you're a resident or you're a medical student, you have that peer support group. I don't think I would have been able to get through medical school without my group of friends. And then it's the same in residency. And then after residency, we do have colleagues and we always have these peer support groups. So you do need that place. Some places like where I'm at right now, at Boston Children's Hospital, they have something for the physicians. It's called the Office of Clinician Support, which is run through the Department of Psychiatry, but it is there when there's an adverse outcome, or where there's a difficult family, when something terrible has happened in the hospital, or a physician really is burnt out, or they really have had a bad outcome. It is through the hospital, and they provide support, and they can do that individually, or they can do it as a group for an entire unit or a clinical team that was taking care of a patient. So there are different things that can be done. There are different initiatives.
Thank you, ma'am, for sharing your experience. Now, just a few questions from the comment box, then we will head towards Dr. Nazish to have a little bit of talk at the end of this session. So let's start from the very below. Shiza Amjad, she is a third-year medical student, and she is saying that, is there anything kind of compassion fatigue that decrease enthusiasm, energy, and indifference, etc., etc.? You can read that as well. So is there anything like that, or these kind of things get better with training? Because definitely you train to become a psychiatrist. It's not like an overnight job. And in that training, you would have learned how to cater with these kind of things. So definitely, what are your views on this?
So I think that compassion fatigue is not something that I would say is like unique to training. Compassion fatigue, I would put that on the spectrum of burnout. So we get fatigued when our reserves are diminished and the expectations surpass what we're able to do. And I think compassion fatigue is one of those markers that you're burning out, that normally you're able to deliver that kind of care, that you don't lose your enthusiasm, and you are invested and not indifferent towards your patients. But if you notice that happening, that may not just be unique to like, this is the kind of patients I'm seeing. That may just be much more an indicator of your workload, the combined stress, or the stress in the system within which you're functioning. And it may be more representative of burnout in general. So I wouldn't say that just because you're in training, you're going to get compassion fatigue. You can get compassion fatigue at any point in training, and you can get compassion fatigue in any specialty. And you can get compassion fatigue as an attending or a supervisor or as a professor, because we're there to take care of patients, and we also need to feel supported in being able to provide that care. And if there's a mismatch of that at any point, you're going to feel it.
Right. So there are two more questions. One is from Anfal. Anfal is a final year student from Allama Iqbal Medical College. And then there is from Sheriar, who is also a fourth year medical student from King Edward Medical University. So Anfal is asking, is it true that the working hours in US is really inhumane and one cannot have, like, actually, I've been talking to him for a couple of weeks now. He is confused between the psychiatry that exists in UK and the psychiatry that exists in the US. So how would you convince him, or like give a 60-second pitch that he should join psychiatry in US rather than UK?
I actually don't know anything about the UK hours, so I cannot speak to that. I can tell you that it is regulated, that there is an 80-hour work week cutoff mandate from ACGME, which is the governing body that looks at all postgraduate training and is responsible for oversight of all training programs in all specialties. So there is an 80-hour work week averaged over 4 weeks in a month. So you cannot cross that. If you do, your program gets dinged. So that being said, there are certain specialties that have more frequent on-call. And there is also programs that might have more frequent on-call. So I can tell you, while I was in internal medicine, my call was more frequent than my call schedule on psychiatry was. So I think as an intern, I was taking call every third or fourth day on internal medicine. I took it once a week in psychiatry. So I think I had more rest. And then in my third year, fourth year, I had no call. And the same thing for our fellows is that there is on call, but they take call for fellowship maybe 4 times mandatory in their first year and 5 times mandatory in their first year, 4 times mandatory in their second year. That's weekend. So it's the rest, if they take call, is on their own volition to make moonlighting money.
Well, moonlighting is very important for us Pakistanis. So getting back to Shehryar, Shehryar is asking that when you become a psychiatrist there is a whole lot cultural difference, because definitely we are from Pakistan. It is not very easy to understand their upbringing and their culture. So how did you fill the gap?
So I remember one of the interviews I had, they, this is not usually done, so I don't want to scare anyone. This was a rare thing, not usual practice, which is when I went for my psychiatry interview, they took me to the inpatient unit and said, interview a patient. And it was a patient with depression. And I just remember reading off my checklist from my USMLEs. And exactly, Shehryar, I think that was their intent, was not to see how well I was able to interview depression. They wanted to make sure I can speak to an American patient and that, you know, I could communicate clearly. So communication, yes, I think is important. You learn where the cultural stuff is, you learn, you live in this environment, you just have to be open. I remember one of my patients said, are you one of those people who learned English by watching Friends on TV? And I had to tell them, no, actually, I learned in school. And it is usual as part of our schooling to learn English as another language. So, I mean, there's sort of like colloquials, you know, colloquial language or, you know, slang. Kids come up with new slang all the time. I can never keep up. I can never come up with their FOMOs and YOLOs and all those other hashtags that's going around these days, but they'll educate me. So you just have to be curious. And if you don't understand something, you just say, sorry, I'm outdated, or what was that you're saying? And can you tell me more about it? But for people who do struggle with language, one of the things is that you just immerse yourself more, you speak more, and you get more comfortable. I can definitely say that pretty much everybody's English improves with time once you come here, or you could do additional classes just to get more fluent, so that and I would say that would be helpful simply because if you're presenting for an interview, for any specialty, regardless whether it's psychiatry, I think psychiatry is even more important because there's so much verbal communication and nonverbal communication as part of your assessment that if you're not comfortable with English or you feel like you get stuck, get some more practice so you do present well during your interviews.
Thank you so much, Dr. Zheala. I would like Dr. Nazish to say a few words, or maybe just put in something within about all we are discussing right now. So, Dr. Nazish, can you please say a few things?
Can you hear me? Because my net is causing problems the whole time around.
Yeah. Yes, ma'am. We can hear you loud and clear.
Yeah. Okay. So I think it was a very, very wonderful session, and Zheala has been a dear colleague, and it gives insight into how psychiatry is, and we need more people like you, Zheala. Psychiatry, definitely, and a role model for the young people. I think we had very wonderful interaction when you visited department with our residents and so on. Telling about sharing your experience, how you came in medicine, and how you sort of managed to merge your interest of arts and drawing with psychiatry. That's been really good. And I think it's wonderful to have ChemPsych invite you, and thank you so much for taking time to talk to all these people and guide them and answer their queries. So thank you so much, and very well done, Yushay and Shiza and all the dear participants as well.
Thank you so much for your kind words. It's just lovely to hear your voice.
Thank you, Dr. Nazish. It means a lot. So, Dr. Zheala, before we wrap it up, can you suggest like two books or maybe two movies that have impacted your life, or maybe some movies or books that you would like everyone to read at least once?
I'm looking to see if I have it. But one of my favorite books is The Little Prince.
Oh, that's an amazing book, actually.
And I remember that in every stage of life when I read it, it's just meant something different to me. These days, I do like another book, which I think is really helpful for sadness and loss, particularly given where we are now with the pandemic and how much loss there has been and how much grief. So it's called Michael Rosen's Sad Book. And he writes it about his son who died. It's a very simple book. It's a children's book. So again, I have children's books. And I love giving my residents and my fellows when they graduate children's books, because I think even though they're simply written, they convey a lot more. And also they invite you into a world of imagination, because that's fantasy and imagination is how particularly children, but all of us, using our internal world makes sense of the world outside. And hence fantasy is so rich and imagination is so critical in both the process of healing as well as just having the will to continue.
Well, thank you so much, Dr. Zheala. It means a lot. And I'm happy that I asked you before. Just to make it clear, I'm just pronouncing this name right because I asked ma'am before. I knew that I wouldn't like to pronounce her name wrong. So thank you so much for finding out time. It means a lot. And definitely 1 hour is a huge time that you have offered us. And take care. And thank you so much for this lovely time.
Thank you so much. I really enjoyed my time. And again, if anyone has any concerns, questions, please feel free to reach out to me. I'm happy to be in touch.
Thank you so much. Thank you so much.
Bye-bye.